Hello, and welcome to the Midwest Regional Webinar on Clinical HIV Testing. Today's topic is implementing state legislation and public health recommendations at clinical testing sites, a collaborative partnership effort between a city Department of Public Health and an academic university health system. My name is Audra Tobin Severson. I respond to she, her pronouns, and I proudly serve as a Senior Capacity Building Specialist at San Francisco Community Health Center, located in Chicago, Illinois. Today, we have the opportunity to hear from our colleagues at Chicago Department of Public Health, also known as CDPH, and University of Chicago Medicine, also known as UCM or U of C. CDPH and U of C will share promising practices that have been identified through the HIV Screening and Healthcare Settings Partnership, formerly known as the Expanded Testing and Linkage to Care Program, or xTLC program, a collaborative program that is in part of Chicago Department of Public Health and University of Chicago. We will be hearing first from Chicago Department of Public Health, who will walk us through Chicago's jurisdiction's HIV funding portfolio and focus in specifically on the HIV Screening and Healthcare Settings Program, formerly known as the xTLC. Chicago Department of Public Health will review the program purpose, model, evolution, and development, as well as sustainable implementation strategies and the impact of the testing program in the jurisdiction of Chicago. We will also hear from University of Chicago, a clinical partner of Chicago Department of Public Health and the lead agency on the HIV Screening and Healthcare Settings Program, formerly known as xTLC program. And we will understand University of Chicago's roles, goals, and the partnership evolution of the program. University of Chicago will share clinical testing barriers and approaches, as well as the program impact and outcomes, including promising practices for clinical HIV testing and beyond. Our first guest speakers today are Ayla Karamustafa. Ayla responds to she, her pronouns. She serves as the Director of Healthcare Access for Chicago Department of Public Health, Syndemic Infectious Diseases Bureau, and the COVID-19 Response Bureau. We also have Patrick Stonehouse. Patrick responds to he, him pronouns. Patrick serves as the Director of Operations for Chicago Department of Public Health, Syndemic Infectious Diseases Bureau, and the COVID-19 Response Bureau. Chicago Department of Public Health, please take it away.
Thank you, Audra. So as Audra said, I'm Ayla Karamustafa. I am the Director of Healthcare Access in our Syndemic Infectious Disease Bureau, formerly our HIV/STI Bureau here at CDPH. So I'm just really briefly going to set the stage for talking about our HIV screening and clinical settings program, also known as xTLC, before we get into some of the nitty-gritty. So as Audra mentioned, and what you see on the slide here is a snapshot of what we call our HIV services portfolio. Essentially, this grid shows you how we've braided our funding across multiple federal and local sources, and in partnership over several years with our planning council and community stakeholders to move away from sort of siloed federal grant funding into a more braided and integrated funding model. The sort of beacon that led us through this process was our Illinois Getting to Zero work plan and the 2 bullet points you see at the bottom of the slide. So increasing viral suppression rates for our jurisdiction by 20% and increasing PrEP uptake by about 20% as well, with the aim of getting to functional zero by 2030. Next slide, please, Audra. So our HIV screening and healthcare settings or clinical settings program lives in our healthcare access program, which every bubble you see on this graph to the left encompasses a series of projects and funding. So again, this program lives within healthcare access and is funded alongside the other projects in healthcare access across a number of different grants, Ryan White Part A, CDC, HIV prevention, and HOPWA, namely, to name the biggest federal funders there. Of course, we contract directly with UCM as our lead agency, who we'll be hearing from shortly with the heart of the presentation. Next slide, please. So the purpose of the program, of course, and this has been true over the course of the decade plus that we've been funding it, is to strengthen our relationships with clinical sites that are doing HIV testing, expand it in areas that we see super high prevalence, higher than 0.01%. Of course, we wanted to weave linkage to care centrally into the process. And I think when this program started, that was a huge priority. That was, not something we had a ton of infrastructure for. Respond to acute HIV infections, which we know show up often in emergency departments and some of the locations where clinical sites where testing is occurring. And of course, take what is sort of central to our HIV services portfolio and implement what we call a status neutral approach. So providing wraparound services, both prevention and care around anyone who walks through the door at any of the sites that we fund. Next slide, please. So a little bit of history on the evolution of the program. So as Audra mentioned earlier, this used to be called our Expanded Testing and Linkage to Care program, or xTLC, which got renamed when we revamped the funding back in 2019. But of course, because it's been around so long, the xTLC is kind of stuck, and that is the name that most of the sites and UCM still use for the program. Initially, it was funded through our CDC PS 1201 grant, and was through a small nonprofit called Public Health Institute of Metropolitan Chicago. Back in 2011, through various competitive processes, the program transitioned to a different lead agency, the University of Chicago Medicine, or UCM, and underwent some transitions that we'll talk a little bit more about throughout this presentation. And again, in 2019, when we launched our HIV services portfolio, we also made the major transition of switching from CDC funding over to Ryan-White Part A, early intervention services funding for the testing. And the primary reason for this was to expand testing outside of the city of Chicago. CDC dollars are limited to the city, whereas Ryan-White allows us to serve the Chicagoland area, the collar counties, and to increase coordination across the sites that are also doing Ryan-White Part A. Next slide, please. So benefits of collaborating with the lead agency: for anyone who works at a health department or a government agency, you know that we have some deficits when it comes to moving quickly and nimbly and efficiently, although that has had to change a little bit during the pandemic. So selecting a lead agency really allows us to expand our capacity and to work with a site, in this case UCM, who also provides this exact service, to provide sort of hands-on technical assistance to the other partner agencies, to be a subject matter expert as a site that actually provides the service, facilitating arguably more effectively peer-to-peer learning as a peer, and again, capacity building and TA. Quick and efficient billing and reimbursement, that's a big one. Large government agencies not necessarily known for being super efficient with contracts and grants and funding administration. So coordinating across multiple sites and making sure that sites are getting paid as quickly and efficiently as possible. And expanding the sub-partnerships during the contract period. So essentially having some of the on-the-ground experience, relationships, et cetera, to continuously be evaluating who's on board and who can we potentially partner with going forward as the field evolves and as testing evolves. And I think that's my last slide, and I will hand it on over to Patrick. Patrick, take it away.
Thank you very much, Ayla. Hello, everyone. Patrick Stonehouse, Chicago Department of Public Health, he, him, his. First slide that I'll be speaking about is HIV screening in healthcare settings, program development, jurisdictional and clinical barriers that we experienced. So the first and foremost was simply that we did not have opt-out screening in the state of Illinois until the beginning of 2016. So this presented both individual level issues and barriers with folks saying no, as well as interruptions to clinical flow as sites were trying to incorporate routine screening, just the process of incorporating, gaining informed consent, reviewing all the information necessary with the individual in order for them to be able to provide that informed consent was a challenge to the flow. Introducing and integrating HIV screening as part of routine healthcare settings in the specific populations and geographies was a challenge as well, but it was something that needed to be done in order to address the low uptake that we were experiencing in the city of community-based HIV screening efforts. The actual integration of opt-out HIV screening into clinical flows at clinical sites was a challenge. It required a lot of direct observation and reviewing of clinical flows in order to try and figure out the most appropriate ways and spots to incorporate the different activities involved in it. And lastly, just by routinizing, we felt that we could address a barrier or a challenge that we were seeing, which was low HIV screening volumes and low linkage to care rates amongst clinical sites in the highly prevalent communities and populations on the south and west sides of the city of Chicago. Next slide, please. So in order to align with the CDC's HIV testing recommendations, with the recommendation being that we would be implementing routine opt-out screening in healthcare settings within communities of greater than 0.01 HIV prevalence percentage, yielding a low threshold, high volume program that, when coupled with the focused efforts, population specific, geography specific efforts that are going on in non-clinical settings, primarily by our non-clinical community-based organizations, would present a balanced approach to HIV screening. So we have our clinical, we have our routine, we have our focused, we have our partner services. All of these things together present this the complete approach that we wanted to achieve. And therefore, CDPH and UCM achieved this balanced approach by focusing clinical routine opt-out HIV testing efforts in the south and west sides of the city. CDPH and UCM also incorporated the use of fourth generation testing technologies within the screening and healthcare settings to create greater opportunities for identifying and responding to acute HIV infections. In addition, in emergency department settings, an HIV lab test was added to routine testing panels. Next slide, please. So when, in terms of aligning with the Illinois AIDS Confidentiality Act, in order to bring about opt-out testing, CDPH was not directly involved in much of this. We provided support, we provided information, but we were not directly involved in all of the legislative work that went into making it happen. This was carried out largely by our community partners, numerous subdelegates, delegate agencies, and stakeholders. But as a result of the amended Illinois AIDS Confidentiality Act, informed consent to test for HIV in healthcare settings was no longer mandated. Informed consent to test was a significant barrier in clinical settings, again, time-wise, flow-wise, documentation-wise. So both CDPH and UCM supported this legislative policy change by aligning our program testing activities with this model. So moving forward, CDPH hopes to expand health department roles and positions at clinical sites that are aligning in-house opt-out testing policies with the amended Illinois AIDS Confidentiality Act. This expansion alleviates or removes completely in-house capacity barriers at clinical sites, transitioning to a routine opt-out HIV testing model. Next slide, please. So in terms of program impacts, with routine screening, we saw immense increased testing volumes in clinical sites located on the south and west sides of the city. When we look at our overall across the city testing volumes, the vast majority are coming from these routine screening efforts, which is to be expected as a low threshold, high volume effort. The program continues to expand to new clinical sub-partnerships that are contracted through the lead agency, UCM. And as a result of the multiple sub-partnerships, agencies serving vulnerable populations in the south and west sides of the city are better networked and improved collaboration. So program expanded sub-partnerships to outside the city, as Ayla alluded to, into suburban area beyond the city limits. So these just continues to expand the impact that such a program can have and the breadth of access that it provides to different members of our populations. Next slide, please. So closing remarks from us at CDPH. So the partnership established new testing standards beyond the grant's general scope of work for the city of Chicago. The scope of screening in healthcare settings program strengthens the reach and effectiveness of the healthcare systems at large within the Chicagoland area. As the lead agency, UCM's efforts is proven highly effective to providers, to peers, and to individual patients who are participating in this program. So partnering with a lead organization or a lead agency historically known for innovation and expertise in clinical HIV testing, streamlines administrative components of the grant, minimizes barriers to successful service delivery while creating a peer-to-peer provider network for sub-partner sites in the south and west sides of Chicago. Thank you.
Thank you, Chicago Department of Public Health. Our next speakers today are Dr. Maura McNulty. Dr. McNulty responds to she, her pronouns. Dr. McNulty serves as an assistant professor of medicine and director of HIV testing for Chicago Center of HIV Elimination in the section of infectious diseases and global health at the University of Chicago. We also have Jessica Schmidt. Jessica responds to she, her pronouns. Jessica serves as the Director of HIV Clinical Engagement for the Chicago Center of HIV Elimination in the section of Infectious Diseases and Global Health at the University of Chicago. Please take it away.
Thanks, Audra. So to start things off, we want to talk about what our role as a lead agency is in the HIV screening in healthcare settings and really reiterate some of what CDPH has already discussed. But one of our primary roles is to implement provider education program and serve as a technical assistance provider for the development and adoption of institutional testing policies at our sub-partner clinics. So this is important in the initiation of testing and linkage to care, but is really necessary over time as different staffing models change, public health trends change. So we've really found this an important part of our work throughout the time that we've been a lead agency. We also facilitate linkage to care coordination for people living with HIV identified through the program, partnering them with Ryan White providers throughout the city of Chicago. We really also form a community network of providers where we recruit and identify clinical partners and create capacity building space facilitated by semi-annual meetings, technical assistance support, and really sharing best practices across the institutions. And finally, serving as a program evaluator and providing feedback to sites. So this includes setting annual program goals for each site, conducting annual site visits, discussing with leadership what opportunities there are for their programs, providing quarterly reports on testing rates and linkage to care, assessing trends over the city of Chicago, and then reporting any concerns that we have to our funders and really helping to support those sites in addressing any changes that need to happen. Next slide. So through this, our primary goals as the lead agency is to, one, implement clinical HIV testing activities that align with CDC's high impact prevention strategies and testing recommendations at the University of Chicago and our sub-partner sites located in geographies with high rates of STIs, HIV, and other morbidities or mortalities from HIV. We also want to integrate routine opt-out HIV screening in these sub-partner clinical sites. And most importantly, establish a community network for providers and peers. Next slide. So as I mentioned, one of the primary goals, and I think one of the most important, is creating this community network of providers and peers that really pieces together our project and allows opportunity to be a true public health initiative and disseminating information. And as CDPH already discussed, this has kind of looked different since the beginning of the project. In 2011, we started with the Southside Health Collaborative and expanded to South and West sides of Chicago, primarily in communities of color. Now, the testing in these places occurred in emergency departments, inpatient settings, primary care facilities. These primary care facilities include community health centers and FQHCs, as well as academic primary care settings. In 2019, with the shift in funding models from CDPH, we were able to move outside of the city of Chicago and add West and South suburban Cook County clinical testing sites as sub-partners, really looking at the Cook County report and seeing where we have highest rates of HIV and implementing routine testing programs at those sites. The partnership with the CDPH has been really important as we rely on their HIV surveillance report annually to kind of look at the areas most in need and work to align our testing and linkage to care activities with their public health implementation. Next slide. So here we can see all the care sites that we work with, and you can, although the colors are a little hard to see, we have our 14 partners on the south and west sides, some just outside of the city limits. And although there's only 14 partners, we actually have 26 locations of care. Next slide. Next slide. Oh, sorry. Nope, go back, sorry. Here we can actually put this in context where we have our maps overlaid with the incidence and prevalence in the city of Chicago from AIDS view. On the left-hand side, you can see our incidence, which is the rate of new diagnosis, the data representing persons newly diagnosed with HIV in Chicago between 2014 and 2018. On the right-hand side, we have our prevalence map, which data represents persons living with HIV in Chicago at the end of 2018. In the map, each map, you can see the darker areas being the areas most impacted. And we can see that our HIV screening partners are addressing those different areas on the south and west side of Chicago.
Okay, thank you. I'll take it from here. So I'm Maura McNulty. There have been a number of barriers over time that are ongoing, but then also some more time-limited barriers that we've experienced over the course of the program. One of the largest has been the competing priorities within emergency departments, FQHCs, and healthcare organizations in general, of gaining buy-in from organizational leadership, providers, and staff to really make HIV testing a priority at their organizations. Staff turnover is certainly a challenge and kind of goes into that prioritization. Especially as once you gain buy-in and certain people leave an organization, you need to continue to work to have buy-in of the existing staff and anyone that comes on. We have partners who have all kinds of different EMR systems, electronic medical record systems, and some are more sophisticated than others. And that certainly presented a challenge with working within limitations of different EMR systems and trying to understand those in terms of what can be done for leveraging those IT systems to support routine HIV screening. In addition, earlier on in the program, prior to 2016, as Patrick mentioned, the legal requirement to have first written or verbal informed consent specifically for the HIV test really made opt-out testing impossible and difficult to implement. And so we have gone through periods of time where we had a more opt-in approach, and that was the language that was used across our sites. And then transitioning to an opt-out approach and the opt-out language has also been a challenge because it's taken time for some of the organizations to make some changes in how they've been used to doing things. And finally, costs. So concerns about what to tell patients about their tests being covered by insurance, who will pay for the test if the patient is uninsured, and just generally making sure that the routine testing program remains cost effective for the patient populations that we're serving. Next slide, please. Okay, so how have we overcome some of these barriers? So we have done it using a variety of different methods. We have identified site champions. So, and even at our own site within our emergency department, it was actually really important for us to identify a champion of the program within our emergency department that could collaborate with us in the section of infectious diseases to make sure that we were really optimizing routine opt-out testing. We do that also with each of our sites. And then we also, present and make a case for routine testing to leadership of different organizations to really try to get that buy-in. We've also worked really hard to form partnerships, and we work really closely with all of our current partners, and then often work more intensively with our new partners as they're launching routine testing, and then more intensely with some partners who may be going through different barriers during a given year, which has happened over the course of the program. We meet with each site at least once a year individually, but again, if it is a new site or a site that's undergoing some specific challenges, we'll meet more frequently to kind of make sure that we're addressing those challenges and supporting the site as best we can. And then we also provide monitoring and evaluation reports and make resources available for linkage and other needs that can also at times be challenging. In some cases, we also offer more hands-on linkage to care support, either ongoing or for a period of time, especially if there is some staff turnover or something like that within their program. And they do need a period of time, the partner needs a period of time where they have someone they can rely on who can make sure the patients are being linked into care in a timely manner. We also offer provider detailing and education on HIV testing and linkage to care and other related topics that providers and staff would like to know more about, such as how to identify people who may need repeat HIV testing, or linkage to HIV pre-exposure prophylaxis, for instance. Finally, we've really tried to leverage IT solutions as much as possible, automating ordering, automating the EMR HIV testing workflows whenever we can, and also automating HIV testing reports and HIV testing results from the EMR to establish a quick turnaround time to identify patients who do need to be linked to care. And then finally, we have an HIV and STI results hotline where patients are able to call in for their test results and receive additional support there if needed. Next slide, please. Some of the main approaches that we've used for testing at our site, I think Jess mentioned some of these are to increase the organizational capacity and buy-in from leadership. And so for some of the larger organizations, that means collaborating across multiple different departments within the organization. So I mentioned we collaborate closely with our emergency department. We also talk to our clinical effectiveness and quality improvement folks, as well as our microbiology lab. They've been a really key partner in making sure that we can implement some of the newer HIV testing algorithms and get a really fast turnaround time for our tests to make sure that we can respond to patients quickly. We do that across other sites as well to support that organizational buy-in. We've also had, over the course of the program, since it has been running for 10 years, we've had the opportunity to kind of convert into newer generations of HIV testing technology, as I think Patrick and Ayla had mentioned, to making sure that we're able to have the fourth and fifth generation testing technologies to be able to identify acute HIV infection and infection as early as possible. Some other important components that we mentioned are really the standardization of clinical workflows, making sure that the HIV testing is included in the general consent to care after the update to the Illinois AIDS Confidentiality Act, EMR modifications when appropriate, and then facilitating patient education and staff education and rollout as well. Okay, next slide, please. Thank you. So our program really follows the CDC's guidelines for routine opt-out testing between the ages of 13 and 64, and allowing, to making sure that we're following that the patient really does have that opportunity to opt out. And so there are certain circumstances, clinically, when patients aren't able to opt out, say if, for instance, in our trauma program, that can happen if patients are not conscious when brought in. And so making sure that we have workflows in place that, as much as we want to automate everything, that we also have those checks and balances that we're still making sure we're aligning with recommendations, national guidelines, as well as the legislature around HIV testing in Illinois. Next slide, please. And I think we've mentioned a few times the Illinois AIDS Confidentiality Act with the amendment for opt-out HIV testing in 2016. So it's still, based on that, it is still required that we make patients aware that we will be sending an HIV test, and as I mentioned, give them that opportunity to opt out if they prefer not to. But at the same time, we've really worked across our partners to make sure that our language reflects that opt-out testing and is not an opt-in model, which we know, it causes a lot of patients to decline testing when we frame it as an opt-in. Next slide, please. So in this chart, the gray line represents total HIV tests by year in the program, with the blue bars representing the number of new HIV diagnoses by year. So you can see here with the red arrow is in 2016, and with the amended legislation taking effect at the beginning of 2016, it really allowed us to ramp up that opt-out HIV testing and overall increase the number of new positive diagnoses we identified using the opt-out language and opt-out processes. Next slide, please. This table here shows our HIV testing volumes from 2011 through 2020 with the number of sites, the total number of tests, our total number of positive tests, and then all the way to the right is our newly positive tests. So you can see that we have generally increased the total number of tests we perform each year. And of course, noting that 2020 was a little bit of an anomaly due to the COVID-19 pandemic. So the program really does identify a proportion of the city's new HIV diagnoses every year. And in addition, you'll note that a good amount of the testing identifies people who were previously known to be living with HIV. This often happens in emergency departments, but also in other primary care settings as well. But we found that it really offers an opportunity for relinkage if needed. We also have, you can also note here, so we have our percentage of newly positive on the right-hand side, that our prevalence of undiagnosed HIV infection still exceeds the CDC's recommended threshold for routine screening of over 0.1%, which is the threshold at which routine screening has been found to be cost-effective, as cost-effective as other established screening programs for chronic diseases. Next slide, please. So this table shows our patient demographics broken down by newly diagnosed and previously diagnosed patients. You can see that overall, the median age of patients tested over the last 10 years is 34 years, with newly diagnosed patients being having a median age of 29 years and previously diagnosed 40 years. The majority of tests are actually performed in women, people who identify as women, while men make up the majority of new and previously diagnosed cases. If you look by year, there have been some years where women have accounted for up to 30% of new diagnoses. And the majority of our testing and diagnoses are in non-Hispanic Black patients. We also see varied risk categories, which is really, the risk categories are really best known within our new diagnoses. And the majority are either MSM or heterosexual. The documentation of risk categories has really improved substantially over time. And so many of the unknown cases are in earlier years of the program. About 20% of our newly diagnosed patients have been identified in an FQHC setting, while 80% in a hospital setting, which includes inpatient emergency departments and affiliated outpatient clinics. Just over a quarter of our previously diagnosed patients were eligible for linkage to care. And we determined that eligibility if by looking at if they're already in care, so saying they would be ineligible if they're already in care, or if they've moved out of the area, or are deceased. The majority of those who are previously diagnosed are already in care at other locations of care besides the testing facility. And so that's where, the overall number that really need to be linked from those previously diagnosed patients drops down to about 27%. Next slide, please. I'll hand it back to Jess here.
Thanks, Maura. So we've talked about testing, and now I want to talk a little bit about linkage to care approaches. Most sites have a team or an individual who is responsible for reviewing all HIV positive results and determining next steps. Each site has its own process and referral pathway based on staffing models. So for example, at University of Chicago, we have a team of physician and social workers who receive positive results in a daily electronic medical record report and notify patients and schedule them the same day or the next day in our clinic. At another FQHC, they have primary care providers who notify the patients of the and then have a community health worker or linkage to care specialist support and help navigate care for those patients. And in hospital settings in particular, Dr. McNulty mentioned 80% of our diagnoses have come from hospitals. The linkage to care partnerships between our emergency departments and infectious disease providers has been a key component for successful testing and linkage to care in community and academic hospitals. Most of our newly diagnosed folks, as I mentioned, are coming in seeking acute care in that emergency setting. So it's been really important to increase testing in those spaces. But as I mentioned, each of these partners that we work with have a variety of linkage to care methods using either social workers, providers themselves, peer navigators, linkage to care specialists, or community health workers. And across these methods, we really work on centralizing the test notification and linkage to care process and workflow at each site, just so that there's someone who has oversight over all of those cases. And all of our patients are linked to care with an experienced HIV provider at the testing partner site of the program or an affiliated site whenever possible. Next slide. Okay, yeah. And just to give some numbers, from 2020 on our linkage to care. So we had 85.3% were confirmed linked to care. And then with a medium time to linkage to care of 8 days. Now our previously diagnosed patients are, a little bit harder to link to care given a variety of barriers that they may have been experiencing. So that rate's a little bit lower, but 65.5% of our previously diagnosed who are eligible were linked to care with a median time for 17 days. So also just, as I mentioned, kind of dealing with a multitude of barriers to that linkage to care. However, we really see it as an opportunity to re-engage those folks in care and provide additional supports when we have them coming through the emergency department. And the baseline laboratory results for our newly diagnosed patients, we saw a median viral load of 78,900 copies and a median CD4 of 291 copies. Although we don't always have that information recorded, but we try to collect it to show the impact of the program. Next slide, and back to you, Laura.
Great, thank you, Jess. So over the years, we've also worked to incorporate other areas that really kind of fit well with HIV testing and linkage to care. So first, in 2014, with the promotion of the CDC's recommended HIV testing algorithm, which, we mentioned that, transitioned to 4th and 5th generation testing that occurred after that. We also align our linkage to care activities with the National HIV/AIDS strategy. So, when the program started, that was really, the guidance was really to link people into care within 3 months. And we've looked to, decrease that as that has been updated to 30 days. So now our goal is really within 30 days in general. However, I will say that with the, newer push through, more and more evidence, and then also through our Getting to Zero initiatives, we're really now looking to do rapid initiation of antiretroviral therapy whenever possible and when it's appropriate. And so these are things that we bring to our sites through our all-site meetings. We talk about it and we start working towards getting some of these processes in place. Our sites are, working towards same-day ART initiation, and some are further along than others, depending on the resources they have available. If they have providers at that location that are comfortable providing that in a safe manner versus if the patients are being referred elsewhere for their initial HIV visit, which could take a little bit of additional time sometimes. But this continues to be a priority for the collaboration to reduce that time to linkage and increase the use of same-day start for ART whenever possible. We have also worked to identify patients for HIV prevention and potential linkage for HIV pre-exposure prophylaxis, trying to work again towards using an HIV status neutral approach, and also have linked in some hepatitis C testing as well, and have some of our sites are doing, a lot of hepatitis C screening and integrating that into testing and treatment recommendations too. Finally, with COVID, we've helped partners navigate some aspects of COVID, and I'll talk about that again in a few slides, but thinking about how to really maintain HIV testing when that quickly became deprioritized during the height of the COVID pandemic. Next slide, please. So as a lead site, we also perform program evaluation activities and information dissemination as well. So we mentioned some of the ways that we do program evaluation, but we really routinely assess program activities and outcomes to determine progress and barriers towards our clinical HIV testing. We have a dedicated data analyst who collects data from the sites and makes sure that we're really on top of what is actually going on a month-to-month basis so that we can quickly identify any bumps or new barriers that sites may be experiencing. We also do quality assurance to ensure the program, that the site is meeting, the program overall is meeting benchmarks, and then that the individual sites are meeting goals as best possible as well. And that really happens through those site visits, and then also our all-site meeting where we give overall feedback on a twice yearly basis to all the sites on the overall program outcomes. From the standpoint of information dissemination, so we also do this through our sub-partner sites through individual presentations at all site partner meetings, and with the broader community through conferences, webinars, publications as much as possible. Next slide, please. So we've really tried, since the onset of this collaboration, we've tried to prioritize dissemination of findings and promising practices through conferences, through publications, and through other means. So this was one of our first publications that described the results of the collaboration over the first 3 years, how UCM acted as a lead site to oversee testing and linkage to care, and some of the successes that we described around forming collaborations between emergency departments and HIV care programs to support testing and ensure that successful linkage to care. Next slide, please. We've also done some other deeper dives into the program. And so, for instance, here we looked at gender differences in linkage to care, and we found that men were more likely to be linked than women when controlling for demographic factors and other things such as HIV status, meaning were they a new diagnosis or a previous diagnosis. So these results were really shared with sites at all site meetings and with the linkage to care coordinators and social workers who assess the needs of the patients who are receiving linkage to care services. And so we were really able to pay some additional attention to barriers to care for women. We haven't yet done a follow-up study to see if things improve, but we did, we have disseminated to the sites to address these specific barriers, and also be aware of assessing the need for relinkage for women as well, and making sites aware of other resources potentially for women, such as the Mother and Child Alliance, or we have a mother-baby clinic at the University of Chicago for keeping women in care with their babies after they deliver. The study also highlighted the importance of screening in women, as they're often not considered as highly for HIV testing. And so over the study time period from 2011 to 2016 for this particular study, nearly 1/3 of the patients with HIV, so both new and previously diagnosed, identified as cisgender women. And women accounted for 31% of all new diagnoses. Next slide, please. In this paper, we assessed the early implementation of rapid initiation of antiretroviral therapy across our sites, specifically for diagnosis of acute HIV infection. So we looked from the years 2016 to 2017 after our sites really had implemented broadly the 4th and 5th generation HIV testing, which allows us to identify acute HIV infection. We found that while overall linkage to care and antiretroviral initiation was very fast, it did vary quite widely by site. However, the sites that did do rapid initiation within the program really didn't require a lot of additional resources, because the routine testing program really supports those linkage to care activities and processes that are already in place. So integrating the rapid initiation of antiretroviral therapy into these existing routine HIV screening programs may be one way to really scale up this, kind of newly emphasized or ongoing emphasized intervention without many additional resources required. We did bring these findings to our all-site meetings to discuss how to improve and more towards rapid start for all new diagnoses, which again, most of our sites are now doing, but with some variability. So it's something that's ongoing. Next slide, please. And so finally, more recently, we've described the impact of the COVID-19 pandemic on routine HIV testing and explored strategies to really mitigate decreased access to HIV screening during the pandemic. We found that at the onset of the pandemic, overall HIV screening in that program decreased by 49% and then slowly picked back up to levels close to the 2019 levels towards the end of 2020. At UCM, we were able to maintain HIV screening rates by incorporating phlebotomy and HIV screening into the evaluation of patients who are coming in with suspected COVID-19 in the emergency department. This approach really resulted in a greater number of patients that were diagnosed with acute HIV infection during 2020. And we're currently working with some of our other partner sites to assess the strategy of linking the HIV test with persons who are coming in for respiratory or other non-specific viral illness, and pairing those testing strategies on a broader scale to see if that impacts the, maintaining the screening rates and also earlier diagnosis of HIV. Okay, next slide, thank you. So in closing, our routine opt-out HIV testing in healthcare settings program is really an important public health strategy to identify people who were previously unaware of their HIV diagnosis, but also an opportunity to identify people who may need relinkage, who are often presenting in acute care settings, and again, sometimes in other outpatient settings as well. We've had the most success by aligning the program with national guidelines and also, of course, paying close attention to and advocating for any policy changes that have allowed screening to be more impactful for our patient population and communities here in Chicago. The collaboration between the clinical sites and the health department has really allowed opportunities to share best practices, strengthen those implementation efforts, and normalize HIV testing as a part of routine care. Next slide, please. So we would like to now acknowledge all of the contributors to the routine testing program, including say Dr. Dave Petrak, who started these efforts at the University of Chicago, of course, the Chicago Department of Public Health, our partners, and then all of our clients and patients.
Thank you, University of Chicago. All right. So of course, we would like to acknowledge our citations that were used as references throughout this webinar. And for questions, inquiries, and support on today's webinar, including capacity building assistance on clinical HIV testing in the Midwest region, we ask that you please contact your Midwest capacity building assistance provider on clinical HIV testing, which is me, Audra Tobin Severson. And you can reach me via email at audra@sfcommunityhealth.org. And on behalf of San Francisco Community Health Center, we extend our sincere gratitude to our guest speakers from Chicago Department of Public Health and University of Chicago. Thank you for your work and for sharing your invaluable, promising practices and giving us this learning experience today. Of course, we would like to thank our audience participants. Please stay in that fight. We are with you. You are not alone, and we look forward to connecting with you in the future for capacity building assistance. Thank you so much, and please have a wonderful day.